Hi, everyone. Thank you for joining us today for the WCI Virtual Reboot. Our topic today is the intersection of severe injuries and the pandemic, parallels between isolation and psychotropic drug use. My name is Phil Walls. I'm a pharmacist and Chief Clinical Officer for MyMatrix, which is a PBM specializing exclusively in workers' compensation. I've been in workers' compensation industry for over 25 years now, and past 14 of which has been with MyMatrix. It's my pleasure today to be co-presenting with one of our clients, Publix Supermarkets. My co-presenter is Niki Moore. Niki is a nurse. She has her MS in nursing, and she is the team leader of nurse case management at Publix Supermarkets. Now, a little bit more about myself. Earlier on in my career, I spent a number of years practicing retail pharmacy. In fact, I was one of the first pharmacists that Publix Supermarkets ever hired. This was back in the late 80s when Publix decided to get into the pharmacy space. And so it's rather interesting that now, decades later, Publix is a client of ours, and we're actually able to do this presentation together. So when we think about psychotropic drug use and mental health, I'm actually going to ask the audience today to step outside of workers' compensation with me for just a little bit, because this is a concern that is affecting the entire country, not just workers' compensation. So let's talk about what I mean by that. First of all, almost 20% of the population, 1 out of 5 adults in America, experiences a mental illness event each year, but only 40% of them receive treatment. Now, when we think about that in regards to other conditions, diabetes, heart disease, something of that nature, 40% seeking treatment would be a horrible number. And yet mental health is discussed so infrequently. That's what happens. People aren't talking about it, and unfortunately, patients aren't always getting the treatment that they should. But it is affecting many of us, considering the fact that our population is about 350 million, and we see that 40 million Americans are experiencing anxiety, and between 50 and 70 million Americans are having problems with sleep disorders. That's a very significant part of our population, and something, like I said, that we do need to think about. Now, tying that back around to the workplace, first of all, mental health costs rank #1 in the US. So this means more than heart disease, cancer, diabetes, other chronic conditions that we think of when we think about what drives our healthcare cost. In actuality, it's mental health. In terms of the workplace, 24% of all costs caused by workplace accidents and errors are associated with insomnia. So think about that, just people not being able to get the sleep they need. And when I look at the drug spend in workers' compensation, I see significant dollars being spent on drugs used to treat insomnia. So the data that we're looking at right now actually originated with MyMatrix parent corporation, Express Scripts. Earlier this year, they released a report that was titled America's State of Mind. And the report was based on looking at the effects of the pandemic and specifically the quarantine on mental health and psychotropic drug use. So they started digging into this and looking at the impact that it had, such that, there's 2 to 3 higher costs associated with patients that also have a mental health condition. US employers are spending $17 billion a year treating mental health issues. And then when they looked at the effect of the quarantine, they realized that the quarantine had an even greater impact. And we started seeing increases in the uses of these drugs. So you've heard me mention now several times psychotropic drugs and some of the drugs that are included in that category. So let's talk in a little bit more detail on exactly which drugs I'm referring to. So we've mentioned antidepressants several times, obviously used to treat depression. There's a number of different drugs that fall into this category, as well as different types of antidepressants. As you can see on the screen, SSRIs, which are selective serotonin reuptake inhibitors, SNRIs, which are serotonin norepinephrine reuptake inhibitors, MAOIs, monoamine oxidase inhibitors, atypical antidepressants, the older tricyclic antidepressants, and a number of drugs that fall into these categories. The SSRIs are typically drugs like Lexapro, Prozac, generic fluoxetine, selective or serotonin norepinephrine reuptake inhibitors include drugs like duloxetine, brand name Cymbalta. Important comment that I want to make there. When I look at data, I know what drug category a drug falls into. That doesn't necessarily tell me whether or not that is the use that the doctor or the prescriber intended. Why? Because drugs are oftentimes used for things other than their original category. They can be used off-label, meaning that it was never approved by the FDA. Now, those of you that have heard me talk before, especially about off-label use, know that my position on that is that off-label drug use is neither inherently good nor bad. It's simply that a matter that there has to be evidence to support that off-label use. So evidence-based medicine, something of that nature. So off-label drug use is fairly common with the antidepressants to be used in conjunction with pain management. Now that SNRI I mentioned, duloxetine, brand name Cymbalta, they actually went the extra step and had a pain indication approved by the FDA. That's not something that we see very often, so I did want to call that one out. The next category there are the anti-anxiety medications. These include primarily the benzodiazepines, drugs like Xanax, generic alprazolam, Valium, generic diazepam, and a whole long list of other drugs that fall into that category. Several things to comment on benzodiazepines. First of all, their use should be relatively infrequent, especially in workers' compensation. Now, so I'm sure there's probably some of you in the audience thinking, well, what about post-traumatic stress disorder? Well, evidence tells us that benzodiazepines are not good even in PTSD. Their use should be very, very limited. They're a very addictive category of drugs. When combined with other drugs that we see all too often in workers' compensation, like opioids, they increase the likelihood of an overdose. And I also want to comment on the utilization that's highlighted there, as needed. There's a Latin phrase that most of us are familiar with because of our familiarity with prescriptions and workers' compensation, and that is PRN. So oftentimes the prescriber will indicate that a drug should be taken once daily PRN or every 4 hours PRN, meaning as needed. In actuality, there's other translations of the Latin for PRN, which is when needed, or better yet, if needed. Now, I say better yet because if you tell a patient to take a drug every 4 hours as needed, more than likely they're going to take it once every 4 hours. If you tell them to take it every 4 hours when needed, a few of them are going to question that and think, well, what does that mean? But if you tell them take it every 4 hours if needed, the light bulb goes off and they'll ask the pharmacist, does that mean if I don't need it, I don't have to take it? Yes, that's absolutely correct. So one of the things that I hope to accomplish during my pharmacy career is to help people make that transition from as needed to if needed. So those little subtle things that can make a significant difference in the way people are compliant with their drug therapy. Next, insomnia. Let's talk about this one for a few minutes. Here we're talking about treating it with a category of drugs known as sedative hypnotics. In our industry, most commonly, we're talking about Ambien. Ambien should be used according to guidelines as well as the manufacturer for about 3 weeks. That 3 weeks should give the treating physician time to talk with that patient, help him or her understand something that's referred to as sleep hygiene. Sleep hygiene is simply everything that goes into influencing whether or not a person is able to fall asleep and stay asleep or not. And it can be very simple things. Having a routine bedtime, decreasing the amount of screen time in the evenings and especially at bedtime, avoiding caffeinated beverages, some very simple practical advice that the Ambien helps them to break that cycle of sleeplessness. They can start getting to sleep. They start focusing on sleep hygienes during this 3 weeks. Then they're taken off the Ambien, and all those activities are going to continue to help them get good sleep. Unfortunately, what do we see in workers' compensation? They're on Ambien for 3 weeks, 3 months, 3 years, way beyond what the guidelines say. Part of our efforts at My Matrix with all of these drugs is to develop a comprehensive pharmacovigilance program, which means we're monitoring this type of activity. We're reaching out, we're educating the prescribers, we're educating the patients, helping them understand the appropriate use of these drugs, basically to enforce the compliance that dispensing pharmacist initiated. And that's a significant part of the goal of what we do. Now, the drugs we've talked about are very typically referred to as psychotropic. Psychotropic simply meaning drugs that affect a mood, sometimes behavior. I think of other drugs as well, and all clinicians may not agree with me, but I think of opioids as psychotropic drugs because they do have an effect on a patient's mood. I also think of stimulants in this category. Now, the stimulants also have a significant tie-in in workers' compensation because of why are we using stimulants to treat an injury? Well, short answer to that is we're not. We're using stimulants to treat side effects of other drugs. And it creates a spiral that can very quickly get out of control. So I'm referring to patients you've seen all too often. They're injured, they're in pain, they're started on an opioid. The opioid, one of the most common side effects is significant drowsiness. You go back to the physician, complain of drowsiness. One rational approach would be decrease the dose of the opioid to minimize the drowsiness. All too often, what we see is to prescribe another drug to offset the drowsiness, which means prescribing a stimulant. And I mean drugs, very powerful drugs, amphetamines, Ritalin, Provigil, Nuvigil, Adderall, very powerful stimulant drugs. What happens when you give a patient a stimulant? Well, now they can't sleep at night. Now the patient goes back complaining of sleeplessness. The doctor puts them on a sedative hypnotic like Ambien. And we see this over and over and over again. Our job with our clinical pharmacy program is to break these cycles, educate prescribers, and we're seeing results from that. Now, as we go on to the next slide, what Express Scripts did in the report on America's state of mind was they started looking at the time of the quarantine. And as you can see from the chart, they started in January, then in February 16th, when the quarantine started, saw an immediate increase, first of all, in the use of anti-anxiety medications, increased 34%. During the week ending March 15th, the use of those drugs spiked by nearly 18%. And they saw a significant higher usage among women than among men. So when I read this report and talked to the authors about the data and their findings, the thought process is, with the quarantine, everything in America changed. People were homebound, their work environment changed, their interaction with other people changed. This led to anxiety, depression, the use of psychotropic drugs started going up. I had two immediate thoughts. First of all, let's look at the workers' compensation population. Did we see the same thing happen to injured workers when the quarantine started? Then we took it a step further and we thought, you know what? Every time there is a significant injury, and by significant, I mean simply that the patient must be homebound, which happens quite often. An injured worker goes through the same impact with following an injury that America did following the quarantine. They're homebound. They may no longer be actively employed. In fact, their job may be at risk. So they're isolated. They're going through the same thing America went through with the quarantine, and they do have increases in depression, increases in insomnia, anxiety, the exact same thing that America was going through. So we started looking at data, trying to see what type of correlations we could find, and looking at, again, at Express Scripts. We're talking about America as a whole, looking at other payers outside of workers' compensation. They went back a few years, and they saw that over a period of time from 2015 to 2018, there was a continuous increase in the use of antidepressants. In fact, it increased 15% over that time period. The other categories they looked at, though, the benzodiazepines and the sedative hypnotics, both went down until the quarantine started. So it was interesting that there were changes that were going on. Another thing that they looked at was, what about comorbid conditions, other physical conditions that a patient may be suffering from? What impact did that have? And what they saw in terms of the prevalence was, first of all, that insomnia was affecting over half the patients that they were able to examine. Parkinson's disease was also impacting over half. Now, I think most of the audience is familiar with Parkinson's disease. What we understand about this disease, at least part of the symptoms are caused by an imbalance of dopamine in the central nervous system, dopamine being another one of those neurotransmitters. And the job here is to, just like with the antidepressants, balancing out those neurotransmitters. Treating Parkinson's is balancing the amount of dopamine that's available in the central nervous system. When these patients are also experiencing depression and anxiety, the treatment becomes more complicated. Another comment about that, where do we see Parkinson's disease most often? Older patients. We're all dealing with an aging workforce. In fact, my matrix published a paper on this earlier this year regarding the aging workforce and how we need to consider the clinical pharmacy management of these patients in a different way than we do younger patients. So we're starting to see all this coming together. So half the patients have Parkinson's disease. They're also going through the concerns with mental health. Almost half had anxiety. Significant number had multiple sclerosis. COPD was almost a third. Inflammatory conditions, of course, arthritis, things of this nature. Cancer, about a fourth. Opioid use, high blood pressure, high blood cholesterol, and then diabetes bringing up the end. What they found was that patients with depression have a 40% higher risk of developing either cardiovascular or metabolic diseases like diabetes. So there is a significant concern between mental health and comorbidities. Same thing applies to our patient population in workers' compensation. So next, they looked at it from a point of view of what is it like when we look across the nation. On the chart in front of you right now, looking at the United States, the brighter the orange shade, the more likely the antidepressant use. So as we can see, some of the Midwest states there, Maine, some of the New England states having the highest, the Southwest, Alaska having among the lowest, and then Hawaii having the least of all. The use being most prevalent in West Virginia at 16.4%, Kentucky, Vermont, and New Hampshire. So with all these patients taking antidepressants, managing workers' compensation, as I said earlier, we looked at the data to see what are the corollaries between an injured worker and America during the quarantine. Several things that we observed. First of all, following the quarantine, we did see a slight increase in the use of these drugs. Now, when I say slight, it was significant, but a complicating factor in workers' compensation is access to data in some instances. There are firewalls for all the appropriate reasons, protection of privacy and things of this nature, so that we can't always see what drugs patients are receiving under their group health or Medicare Part D, Medicaid, whatever the other payer might be. So some injured workers might receive antidepressants and other psychotropic drugs through the workers' compensation system. Others are going to only receive certain drugs through workers' compensation, and they might be treated for depression or anxiety through their group health care plan, which is data that is not visible to us. Then further complicating this, as I mentioned, is off-label use. So we can't always look at a patient taking an antidepressant and make the assumption that they're taking that antidepressant to treat depression. There's also a significant likelihood that that antidepressant is being used off-label to treat pain. So looking at all this, we started digging into our data, looking at regional areas. the way Express Scripts did on the map in front of us, and also then looking at different clients. We did not see the same distribution regionally, but among our clients, we did start seeing some differences. And I came across one client that was very, very interesting because we did not see the same impact on the increase in psychotropic drug use that we did with other clients and other regions in the country. That client was, of course, Publix. So we started talking with Publix, Niki Moore in particular in their case management division, and we found out some very interesting things about what Publix was doing, how they had embraced psychological assessment and other tools that were available to them. And so as not to steal any of Niki's thunder, again, I'd like to reintroduce Niki Moore. She is a nurse. She is the team lead in nurse case management at Publix Supermarket. And Niki, I'd like to hand this off to you at this time.
Thank you, Phil. The data that you provided is pretty impressive. You have mentioned that we need to start saying when needed versus as needed. Simple changes in our conversation and terms can truly change the mindset of our injured workers, and we will cover some of this soon. Today, we're going to look at the Publix story, psych in our work comp system, strategies to assist our injured workers, and then we're going to go back to Phil to go over some final points. Data drives a lot of difficult decisions in workers' compensation, and my hope is that we start having these discussions before the data matters. Today, we're going to cover issues with the psychiatric referral and some strategies to assist. As we started looking at our cases, we separated them into 3 categories: new cases, atypical cases, then mature cases. Each of these categories contain their own issues, their own special set of circumstances, so the suggestions we discuss next will not work for every case. Often when people find out that I'm a nurse in a grocery store, they comment about how wonderful it must be to sit behind a desk, and I just smile. I really do love being a nurse for a grocery store, but what they do not know is that workers' compensation is the hardest field in medicine. Why? Because it's the only field in medicine where patients are rewarded or incentivized for not getting any better. Now, that does not mean that all of our patients don't want to get better. It just simply changes our approach in helping them receive the best care possible. When Phil asked me to speak about psychotropic medications, my eyes lit up. The only topic I love more is opioids. Drug addiction has affected my family like many of you. A lot of people think that drug addiction is only illegal street drugs or opioids, but as Phil mentioned, it can be psych medications in the form of benzodiazepines, sleeping pills, or a combination of several. I always love to tell the story about how Phil came to Publix 7 years ago, and he told me that I had an 83-year-old drug addict on our books, and I was floored. This really did help shape my passion in appropriate medication management. To give you a little background on me and how I fit with psychotropic medications, about 10 years ago, I found myself in a bad emotional space. I was crying constantly and angry. I was one in the 5 cases that Phil mentioned above. I went to my PCP and I was put on Lexapro. But what I found with the Lexapro is that it did not fix my problem, nor did it teach me how to fix my problem. And for those 6 months, I just wasn't myself. I can tell you that it was a slow process to safely wean myself off the medication, and it was not a very good time in my marriage. So today, when I talk to you, I really am speaking from the bottom of my heart and not just about the bottom line. It is our duty to do the right thing, and sometimes that is not medications. I'm so grateful that I work for a company that allows me to use my passion to create better outcomes that are focused on the patient and not the dollar amount. During the pandemic and shutdown, we stayed open. Our employees who may have not been considered important now became essential, and those words meant something. Shoppers, for the most part, were appreciative, and we felt loved. Well, except when the people were fighting over the beloved toilet paper. Simple compliments and the feeling of pride can change one's emotional psyche. Now let's look at problems with the psych and the work comp system. After reviewing our older mature cases, I used to cringe when we would get a psych referral because I knew what was coming. We all have gotten that feeling from time to time. I knew that we would have long-term psych medications that typically would not stop until that file settled, or there were medication compliance issues. Currently, we have not discovered a source or a network that provides us a resource for psychiatric or psychological providers that are trained in workers' compensation. Our options are really limited, and there's no one that provides the training necessary to these providers on how to best assist the workers' compensation patient. We knew we had limited resources for this, so we had to develop other options. This started us looking at types of providers we utilized. Psychiatrists, who typically provide medications, neuropsychiatrists, who also provide medications, but their evaluations and testing are more in-depth than I typically see in the psychiatry reports that we review. Then the psychologist or the licensed therapist who can provide sessions to discuss the issues and offer cognitive-based therapy with exercises that help retrain the brain. They offer non-medicinal solutions and serve best with temporary conditions. New cases. Now, when you look at your new cases and you receive that request for psychiatry, the first thing you need to determine is if this is related to the work injury. Most people won't like that statement, but we all know it's true. Once compensability has been established, then it's important to figure out what piece of the injury necessitated the referral and if this is just a temporary condition. A temporary condition is due to being off work, financial issues related to being off work, or not being able to do certain tasks or hobbies. A non-temporary condition would be a traumatic injury, and we'll discuss those injuries in the next section. Getting prior records for these new cases can be helpful. They can assist the psychological provider in determining the triggers that cause the condition and how to best assist. Comorbid conditions play a huge role in recovery, as noted in Phil's slide. He mentioned that a patient with depression has a 40% chance of developing cardiovascular or metabolic disease. 40% chance? That's quite high. Once you know the cause for the referral, it will help shape your next steps. Is this due to a temporary condition or issue that you can potentially help get adjusted? For example, if the patient's off work, is there a potential return to work date planned? Or if the depression and need for psychiatric referral is due to a hobby that the patient can no longer do, can therapy work with the patient on ways to continue that hobby or modify their ability to do it? There is an old Chinese proverb that most of you are probably familiar with. You give a man a fish and you feed him for a day. You teach him to fish and you will feed him for a lifetime. Sometimes the best solution is to help our injured workers overcome their fears and issues, and sometimes it's just talking to an impartial participant and being provided with the tools for modification of the thought process. Prior to attempting medication management, you can ask the referring physician for an alternative provider. For example, I like to ask for a psychology referral trial with only 6 to 12 visits. This allows for CBT training prior to considering a psychiatric referral for medication management. Keep your provider updated on how the visits are going, and once the visits are complete, then ask if the psychiatric referral is still indicated. Sometimes cases are a little bit more in depth, and maybe a neuropsych evaluation can get to the root cause. The testing they can complete can be really helpful for any treating provider to determine an appropriate treatment plan. Don't be afraid to talk to your physicians. From the beginning, ask what the goals are and a timeline to meet those goals. If ortho refers for psych due to financial issues from not working, work with them and ask questions. How about a conversation something like this? Dr. Jack, I see that you've made a referral for psychiatry for Mrs. Herding due to financial issues related to being off work. We have light duty available if Ms. Herding was able to lift 10 pounds on occasion. Would it be appropriate to have therapy work with her on that goal of having her return to work in 6 weeks? And maybe in place of that psychiatry referral, could we offer Mrs. Herding 8 visits of cognitive-based training with a psychologist so that her transition to work will be easier? Now, I think it would be hard to argue with the above question, and you are truly trying to meet the needs of the associate. Also, you are setting measurable and clear goals. If the physician says no and still wants a psychiatry referral, have a conversation and again ask for clear and measurable goals. Make sure they have reviewed them with the associate, and also don't forget to review them with the treating psychiatrist. Conversations can start with us, but we also need to make sure the physicians are communicating well, or at least getting each other's notes to know what we're trying to accomplish. Atypical cases can be some severe traumatic injuries that require immediate services. And for these types of cases, we want to make sure that you're utilizing the appropriate providers. For example, with an amputee, early intervention may be key to recovery, especially with the right provider and therapist. We have received some of our best referrals and support from our vendors that supply artificial limbs. We found that some of them have been through similar conditions and have been very beneficial for our files. A prior amputee has a lot to offer and can be a great support system for a newer amputee. And as you know, with the amputations, early intervention really does help, not only with therapy, but also potentially asking for a psych referral early on. For any file where there is a mention of suicidal ideations, please jump immediately to the trained professionals to consider if Baker Act is appropriate to avoid injury or harm to self or others. Phil mentioned above off-label use of psychotropic medications. This is also another discussion that you need to have with a physician, and make sure the need and condition that they're being used for are clearly documented in the physician notes. You should be asking if there are any alternative medications with less side effects. I have a clinical pharmacist at my matrix that I abuse frequently with this type of question. I have my options in hand when I go to that physician, and I'm ready to ask all the questions I need. Then we have medications that help patients sleep. Our experience with these, and if you talk to your My Matrix pharmacist, they will explain to you that these should be used for only a very short term, possibly just 1 or 2 scripts. Discuss this with the physician and ensure clear timelines are addressed along with the need. After a surgery, we tend to ask the physician for a minimum or a maximum of 30 days, as they will need some sleep to recover from the surgery, but don't need to continue on these meds long term if recovery is happening. Now we're going to look at our mature cases. A lot of times when I get involved with an older case, it's when an MSA has been completed and the cost of medications are through the roof. If we start looking at our cases earlier, we shouldn't get to this point, but we all have these cases lingering. The path of these files is not likely to change without settlement. They're really hard to deal with, and usually at this point, very difficult to change the medical path. I've been told many a time, we can't make them do it. And I know we can't, but let's please ask questions and start having conversations. A deep dive medical review on these files is indicated and appropriate. I always recommend that this is done by not only the nurse, but the adjuster, maybe a team leader, maybe even management, maybe even a peer review. But it's always helpful to make sure that the patient is compliant with the medications prescribed. We have been successful in completing drug testing through a couple of our psychiatry offices using oral swabs. Now be mindful that certain medications cannot be tested using oral swabs, so urine testing may be required. To interpret the testing, you need someone who's qualified in the testing process, as there can be a lot of confusing numbers on those reports. Through Cordant, we've been able to ask questions and learn through their medical directing team. It is so nice to have a phone number to call and reach out to ask questions about when a hydromorphone should be positive if a patient's not on morphine, or duloxetine, or which benzodiazepine was tested for. Case example on this, talking about a mature case. We had a 46-year-old male with a significant injury back 15 years ago. Now, although this injury warranted psychiatric referral, and by all means it was provided, we never questioned it. But here we are 15 years later, and we're still on psychiatric medications. The medication spend was around $5,000 every 3 months, and that was just for the psychiatric meds. When we asked the physician for the drug testing, what we found is that the patient could not produce urine on the first 3 visits. So we came up with a new plan, and we switched to the oral swab kit, which we knew would not test for all of the medications that he was prescribed, but it did hit the majority of them. Surprisingly, the patient tested negative for all of the prescribed medications, yet positive for marijuana. The physician quickly stopped prescribing these psychotropic medications and allowed the patient to self-medicate on their own. But again, drug testing can be difficult to interpret even for physicians. I cannot stress this enough. How many times, even with our opioid program, that we've had physicians not be able to interpret drug testing appropriately. And then I have some that blow me out of the water. Through Cordant and their medical directors, I can make a phone call, I can supply the number to the doctors, but more importantly, their testing is pretty easy to read. And it's important to have that partner who understands the process and helps your staff determine what the true results are. To finish up, no case is the same, and there is not a solution that fits every file. But every person deserves the help they need to get better. Just know that sometimes workers' compensation is unable to fill the voids in a person's life. And no matter how much we try, they may not get better. If you are intentional and you push for a treatment plan that benefits the injured worker with clear and measurable goals that are attainable and realistic, then everyone wins. Sometimes these aren't the most cost-effective measures, and they will affect your bottom line. But so will psychiatric medications being used long-term. I'm going to finish up with another Chinese proverb, and then I'm going to turn it back to Phil. Better to light a candle than to curse in darkness. That could fit any of us: the injured worker, the doctor, the adjuster, the nurse case manager, the manager, all of us. Go ahead and light your candle. Now I'm going to turn it back to Phil.
Niki, thank you very much. There was a lot of good insight into what you talked about, and I just want to comment on a few of those. First of all, I know with working with our behavioral care partner, CareRisk, early intervention is vital in having the impact that we've seen in your data at Publix. And I think you definitely presented that well by recognizing early on the need for a referral to a psychological assessment. Mentioned earlier, my career in workers' compensation has spanned over 25 years. I think it's interesting, when I first started, this was back in the mid-90s, the number one drug in terms of both cost as well as concern from our clients was Prozac. This was obviously before the opioid epidemic. And our customers were concerned about the use of Prozac for 2 reasons. One, it was brand only at that time and quite expensive. But 2, there was a saying back then, don't buy the psych claim. I think we've seen a lot of progress in a decade and a half. And I think the saying today should almost become, you must buy the psych claim, and the earlier the better. I think you've demonstrated very clearly that early intervention is going to have a huge impact. I also love the way that you tied this into drug testing with partners like Cordant. Having information like that is vital. I can track data in terms of what is dispensed, when it's dispensed, when it's refilled, what doctors are prescribing, what they're not prescribing. When it comes down, though, to whether or not the pill is going into the patient's mouth, we have to have something like urine drug testing. Again, early intervention is better. In fact, many people support the use of baseline testing, The only way, in many cases, you can know that someone is not taking illicit drugs at the start of their therapy is to test them before they start taking the prescription drugs. So I also want to thank our audience today. I hope you have found this beneficial. If you do have questions about implementing a behavioral care program, please reach out to your MyMatrix clinical account executive if you're one of our clients, or if you're a client or a prospect, you can always email us at clinical@mymatrix.com. Thank you again, and we hope this was beneficial to you.